ه- هنبدأ. أنت في عندك أي ملاحظات الفترة اللي فاتت؟
لا تمام يا دكتور، اوكي.
طيب طيب، خير إن شاء الله إن شاء الله. طيب أنا هعمل شير. بسم الله الرحمن الرحيم. هل أنا ليا حق أعمل شير؟
Go ahead يا دكتور.
Dr. Muhammad, just to be all in English because we have participants that speak English only. Thank you.
Oh, thank you so much for these notes. Thank you so much, Professor Abir. Thank you. بسم الله الرحمن الرحيم. Okay. بسم الله الرحمن الرحيم. So why I am not able to share? I don't know. I will. Okay. Bismillah. Now uh, I will share. So بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. This is Dr. Muhammad Yusuf. I'm a senior professor of surgery at Cairo University. It's my honor that I'm a board member of Humanitarian Health Hub, and I'm the founder of Integrated Medical Academy. Today, I think we have a very, very important subject. We'll talk about why disaster environments demand a new healthcare paradigm. And we will propose an integrated five-pillar approach. And I think all my colleagues, all the board members will tackle the details. I'm just trying to present the global vision we have. So, Asma, actually, last time, yes, okay, Alhamdulillah. No, I think, yes. So, in this webinar, we will talk about why and how. Why what? Why this case of changing healthcare in disaster environments is mandatory. And we will display some important facts. We will talk about numbers, and these numbers are not ours, it's the WHO. It will be the ground reality. And we will discuss the main problem. What is wrong with the current approach, and how this is the proposed five pillars we will talk about. And we will suggest some values, guiding values during our new approach. And at last, we will ask you, my friends, the attendees, to join us. Really, I love these verses, this ayah. ومن أحياها فكأنما أحيا الناس جميعا. Allah Azza wa Jal is talking about humanity as one soul equal the whole humanity. And the translation, and whoever saves one, it's as if he had saved mankind entirely. So why it's again Bismillah. Okay, so why change is mandatory? Actually, if we will dig in, you will be convinced that it is mandatory. There is a total resource collapse. So no labs, no premises, no imaging. So there is a different medical reality. All the tools, the expertise are not available. And actually, the WHO confirmed this. WHO stated clearly more than half of the whole world lack access to proper health care. In these circumstances, emerging and neglected cases and disease are many and many. For example, in Gaza, a lot of patients needs plastic intervention, vascular, multidisciplinary approach, and so and so. And this will not be the only case. This will be repeated day after day, week after week, year after year. And to validate evidence, we need practice. And actually, we are practicing. What the WHO numbers says about this case, as I just mentioned, 4.5 billion lack essential health care. So 50% of the whole world without adequate health care. And it was very strange for me to find this number. 1.6 billion live in settings of conflict, displacement, and natural disasters. So siege, poverty, disasters, environments are increasing more and more and more. We just mentioned 3 examples: Gaza, Sudan, Lebanon, Sub-Saharan Africa, and more and more. In Sudan, they call it the world's largest humanitarian crisis, more than 25 million in bad healthcare status. So let us consider some issues regarding the normal practice mindset which affect this change move. Problem number 1, the modern medicine is nearly totally dependent on investigations, labs, radiology, ECG, special tests, and so and so. And there is nearly complete denial of complementary medicine, which is under use actually. So our integrated approach, I'm talking about at least 5 pillars. Number 1, we are looking to exhaust all digital remote support, teleconsultation, teletraining, to create a digital warm community, doctor to doctor, connecting isolated clinician to global expertise. The second important pillar, I think, is changing the setup of training for resilience. And resilience meaning empowering health professionals to work under restricted resources and emotional and workload stresses. The third important is to empower communities so that people can help to what you call minimize the load on the healthcare system. They can give care at home. They can give some sort of support. They will fill the gap between a clinician and healthcare. As I mentioned, complementary medicine is an integral part of these circumstances and this environment. And we suggest out-of-the-box approaches. Go to the past, see the history, you will find amazing modalities. And dig in traditional systems like Chinese, Arabs, Egyptians, and of course, not to forget the AI advancement. And you will find the answers about these questions. So the pillar number 1, I will just highlight points because, as I mentioned, my colleagues and friends, the board members, will speak about this in details just after a few minutes. Teleconsultations, we suppose that this is a very important component of the first pillar, and creating a warm doctor-to-doctor supportive community, teletraining, and I think my friend, my schoolmate, actually, Professor Atif, will talk about teletraining. And we suppose that remote teletraining nowadays can be an amazing tool for changing mindset and changing practice. And the global mentorship fellowship, I think this is another modality of which is a part of remote support. Pillar number 1 and pillar number 2, are related to training, whether training health professional and empowering a community. I will give just quick examples of training for resilience. To train young doctors to have the mindset of specialists in a way, in crash practical courses, and to train them on skills. Yes, skills. You can train young doctors and young health professionals by using simulation-based training. If you will follow the do-it-yourself principle, you will get amazing results. And of course, the training programs will train health professionals not to depend on investigations. Empowering a community through remote support. If you will structure health awareness campaigns to let the public know about the red flags, and then select champions to let them to be able to fill gaps. And also, I believe it's very important to create a middle layer, like the midwives, and I will say it in Arabic, al-Mugabbarati, who is an intermediate person between the orthopedic consultant or orthopedic specialists and GPs. And this all of this is a part of an integrated digital empowerment atmosphere. And last but not the least, to integrate complementary medicine with its different modalities: herbal, acupuncture, hijama, honey. And these practices evidence-based. This is not few cases. This is evidence-based. And I think it's due time to integrate complementary medicine in the conventional therapy, especially in low resource and restricted areas. And as I mentioned before, the out-of-the-box approaches, history, traditional system, and by these 5 pillars, hopefully, we can reach a time, and hopefully this will be soon, to create new protocols for the restricted environment. And sure, these protocols will not be a copy and paste of the North guidelines. So in the next slide, I think I will talk about some values. We believe that these values is very important during applying this new approach. Agility is very important. So to be perfect is the enemy of agility. Start, work, expect mistakes, correct yourself while you are moving. So 50% solution is better than 0. And how to combine flexibility and structuring. To be rigid enough to be reliable, and flexible enough to function when everything breaks down. And I think we have to redefine innovation. The most powerful innovations in low resource settings are not new technology. They are how to use available resource. And I think this is very important. So why is constant, but how is very, very changeable. The next point is we should be what you call open to others' experience, learn from the past, learn from others, and again, 50% is better than 0. The last value, we don't have a t-shirt which fits all, but one size does not fit all. What fits people at the north does not fit people at the global south. What fits people in Gaza may not fit people in Sudan. Okay, why I'm not able to انصح يا أستاذ محمود.
Uh, there is an arrow below يا دكتور. You can press the arrow below.
افندم
يعني
اعمل ايه؟ اسمع، انا مش عارف.
في سهم تحت يا دكتور في
انا والله بدوس عليه او مش عايز يحرك. طيب انا هعمل حاجه كده. بسم الله، مش عايز يجي.
Can you use arrow on the keyboard?
والله مهنك.
Yeah.
I'm trying. Okay, I'm trying. اعمل ايه يا حاج محمود؟
نقفل الشير.
لا، ما ثانيه واحده. انا طب اوقف الشير وارجع تاني.
ايوه.
ستوب شير. اوكي. بسم الله الرحمن الرحيم. بسم الله الرحمن الرحيم. طيب هل انت تعمل احسن او؟ طيب، بسم الله الرحمن الرحيم. I have طيب انا عايز اصغره واكتفي بال
بريس اسكيب كده.
ما هو لو كانت مشكله، ما انا اهو دوست مش عايزه تيجي، يعني هي
هو
المشكله.
هو كده مينيمايز ده باي ذا واي، يعني مش فول سكرين.
طب انا قدامي فول
يعني
سكرين.
احنا شايفينه مش فول سكرين.
ما انا بقول لك انا قدامي فول سكرين. طب انا بحاول اعمل اي حاجه. بسم الله.
غير.
اوكي. اوكي تمام. So what we are doing, Triple H and IMA in Gaza, we actually we had a platform of teleconsultation. Kusara will speak about it, and we have tele awareness campaign and public health education. And I think Dr. Asma, Dr. Asma will talk about. And we have a warm doctor-to-doctor community, supportive, and Dr. Ahmed will talk about it. And the tele-training, and I think this is a peer we have. It's one of a kind. Dr. Atif will speak about the published research and the importance of documentation. Professor Abir will give few words about, and Dr. Khalid will speak about the global mentoring fellowship. And I think this global fellowship is one of a kind. I believe it. So let us sum up. We have some dynamic numbers and milestones. Again, we are going to teach. We have a program for 200 interns in Gaza, and this program is endorsed by health authorities there. We have, alhamdulillah, a community, global community, 1,500, and we have at least 200 mentors in the global fellowship. And as I mentioned, these actually this activity is going on. We are not proposing, but this is going on. So I will finish. I'm sorry, Asma, أنا طولت. What we are starting to document, I think documentation is very important to validate our experience. We are documenting clinical outcomes, teleconsultation data, community impact, dermatology finds. We have now 2 papers, I think, published, and we will assess the do-it-yourself simulation. And actually, I can say Gaza is the world's most extreme test of this model. It's the hardest possible proof of concept. So now we are in phase 1. We are documenting all outcomes. So I can say it loudly: Gaza is not only a humanitarian crisis; it's a proof of concept laboratory for healthcare at the limits of possibility. So at last, please join us. How? You can be an instructor, develop and deliver online modules with us. Be among the team who is giving teleconsultations, whether to peers or to patients. Help us to reach other doctors. Be in the research team, co-design validation studies. Be partner with us, and if you are a funding bodies, you are more than welcome. So to sum up, to conclude, Gaza, Sudan, and Lebanon are not waiting for a better future. They need a functioning present. The knowledge to build it already exists in history, in tradition, in our practice, in our community, in digital technology. Our task is to find it, validate it, and deliver it. Thank you so much. Actually, we put this caring globally and healing locally. This is the role of humanitarian health hub. Thank you so much.
Thank you so much, dear Prof. Muhammad Yusuf, for this comprehensive presentation. Our next speaker is Prof. Atif Abdelazim. He is Emeritus Professor of Rheumatology at Cairo University and the Chairman of Integrated Medical Academy. Unfortunately, due to some issues, Prof. Atif is unable to join us live tonight. However, he has prepared a recorded message for us, which will now share with you. Mr. Mahmoud, if you kindly share the presentation of Dr.
Introduce myself first. I'm Dr. Atif Mahmoud, an Emeritus Professor of Internal Medicine and Rheumatology at Cairo University and a Fellow of the Royal College of Physicians of UK. I am going to go with you through the Integrated Medical Academy, which is one arm of the Humanitarian Health Hub, which was founded by Dr. Muhammad Yusuf. Dr. Muhammad Yusuf has kindly assigned me to be in charge of the Integrated Medical Academy. So what I'm going to go with you today is to talk to you about what's Integrated Medical Academy, what its mission, vision, and what we have achieved and what we still have in the pipelines. So the Integrated Medical Academy, or IMA, is a platform. It's an online medical educational platform which was designed especially for healthcare providers in areas of low resources and areas of disasters and conflict. And we depend mainly in this platform on building up clinical skills, making easy decision making, and we are very clinically focused by symptom-based approach. And we are submitting this information, keeping in mind that these are the professionals who are submitting the information are given to non-specialists. So with that in mind, and using the AI power to develop some video narration and decision-making algorithms, we have started working for the IMA. So for whom the IMA is built up and who is going to benefit from that? Mainly doctors and specialists in remote or areas of conflict and low resources. Also, we have a complete program for newly graduate interns and for nurses as well as clinical pharmacists. So this is the healthcare providers, but we have also a program for the community health workers, mainly the volunteers, who are the first front line responding to the crisis. So our mission is very clear in the IMA that we need a world where every person can receive an excellent medical health care, and we are powered by not sophisticated investigations, but by human skills and expert knowledge. To achieve that vision, so we have to deliver the care to our patients everywhere for everyone who needs it through an online training design programs. So we train professionals, and we have also developed some programs for online surgical skills. And we are empowering the public by giving them more education about infection control, about how to deal with the patients to submit the first aid. And last but not least, we're working on building up database so we can have some publications and research about the work we have done. The programs that we have developed are divided in two main groups. The medical programs, which include doctors, nurses, pharmacists, and the interns training program. The non-medical programs that includes communication skills, basic research skills, and the AI healthcare usage for machine learning and for clinical tools usage. We are still starting the non-medical program, so we don't have any material to launch on the platform so far. Let me focus on the doctors program because that is the main work that we have done so far. We have programs for cardiology, for non-cardiologists, for endocrinology, for gastroenterology, hematology, and dermatology, rheumatology, obs and gynae, and infection control. And we have focused mainly on the major topics in these areas, which general physicians or emergency physician can face as a frontline physician health, taking care of patients in these remote areas. For the interns training program, which we have started recently, we have launched 5 programs so far: the basic life support, the shock management, ECG interpretation, laboratory interpretation, radiology interpretation for non-radiologists. So we mainly focus on the plain X-rays and ultrasounds. We do not give any courses on MRIs or CTs because we assume that most of these facilities are not available. We are building out now surgical, pediatric, internal medicine, obs and gynae, and emergency programs for the newly graduate physicians, which I believe will be all available in the coming few weeks. Nurses program has a very rich program which include trauma care, emergency response, and triaging patients, how to assess patients in the emergency room and triage them, the medication administration, the IV therapy. Beside that, there is courses about infection control and mental health for patients as well as for the healthcare providers, the resource management in these settings, as well as pediatric and obstetrics emergencies. There are 5 modules now. We're working on 5 modules with some sub-modules, and these modules will be delivered and will be available on the website, in our website, in a matter of a few weeks' time. For the pharmacist program, we have
I think it stopped the video.
Actually, yes, I think I can't hear. Mahmoud أو Asma, would you please check?
Okay.
طيب أسماء، يعني لو النكست سبيكر يبدأ لحد ما نفيكس المشكلة.
Okay, تمام. ممكن نعمل كده. Our next speaker is Dr. Sarah Hindam. She is a pharmacist, a business development consultant, and the head of our doctor-to-patient consultation system. She will share with us how no doctor in Gaza needs to face a crisis alone. Dr. Sarah, the floor is yours. You can now share your presentation and start.
Thank you, Dr. Asma. Hello, everyone. I'm Sarah Hindam. I'm a proud member for Humanitarian Health Hub. I'm here today to talk about one of our services, the teleconsultation. But before that, I'd like all of us just to take a moment and imagine that scene. A city under siege night after night, the streets glowing with fire, building rubble blocking every road, and a child, a small one, frightened and just in pain. This child, just a bandage on the forehead is not enough to ease the pain, and there's no clinic nearby. Rubbles blocking every path and checkpoints seal every road. And there's no way out, neither a way in. What do these people do? From this question, it comes what we do and what we do now, the medical consultation. A remote service that help those people. The core idea of our medical consultation is very simple. It's just we bring the doctors to those who cannot reach one. In areas of siege, conflict, and disaster, the local medical staff are always under unbearable pressure, and the patient cannot afford the luxury of waiting. So the service we created to provide diagnosis, guidance, and medical follow-up remotely, and sometimes using natural alternatives, as Dr. Muhammad mentioned, was our only way to help those people. We start because the resources are scarce in those areas. We built our methodology around what is available, the symptoms, the detailed medical history, photos and videos, without burdening the patient with tests they cannot access. Any case requiring emergency, of course, we direct them to the nearest medical facility. But how do we provide a medical service in an area that barely has internet access? The answer was practical and simple. We all have WhatsApp and Telegram, not because they are ideal, but because they work even with weak internet, and that's what the patients have. So we have to work with them. The last 2.5 years, through these simple channels, we reached around 6,000 people and received more than 4,000 medical consultations across many specialties, covering almost everything patients need, from pediatrics, internal medicine, surgery, OB and gynecology, dermatology, rehabilitation for neurology, psychology, and more. The service never stops. The team of general practitioners, the primary care physicians, and nursing staff work always 24 hours a day. They receive the case from the patient, then refer them to the relevant specialist. Thank God, more than half of the cases showed clear improvement. This is the reason that encouraged us to continue and give us hope. We didn't stop there. 3 months ago, we launched a distinct new initiative, the medical community on WhatsApp, bringing together doctors from inside Gaza with their counterparts from countries around the world. 30 medical specialists in one place to exchange expertise and make joint decisions on the most difficult cases. You will hear more, of course, on this initiative from Dr. Mitwalli, the program coordinator. On parallel to this, we're currently working on launching specialized clinics in the fields that are needed most and present the least in conflict zones, such as rheumatology, immunology, endocrine, and hematology. Also, we are developing a comprehensive application to store the patient medical record and medical file and address all the challenges we faced through the 2.5 years ago. And of course, not to forget to expand geographically. It has already begun in Gaza, and now we are reaching to Sudan, Lebanon, and other areas in need. In addition to all this, we believe that prevention and health educators are an inseparable part of medical care. Therefore, we have published around 40 awareness topics in simplified Arabic with short video clips and on scabies, burns, fracture, first aid, and more. We as doctors and healthcare providers, wherever we are, cannot tolerate silence. when somewhere in the world is burning and the people there need our help. We invite everyone to be part of this humanitarian act and do whatever they can do in many fields, as Dr. Muhammad mentioned earlier, in being a doctor, being a trainer, being a marketing field, in any way. And that's all we need from everyone as a human being. That's all from now. This is as simple as I can describe the teleconsultation. However, the effect we're doing is huge. You will feel it when you try it by yourself. Thank you for your time, everyone.
Thank you. Thank you so much, Dr. Sarah, for the enlightening presentation on the doctor-to-patient consultation support service, which highlighted a vital principle that no doctor should ever have to navigate a difficult case or crisis alone. I'm glad to note that Engineer Mahmoud's connection has been restored, so I would like to invite him to resume the presentation of Dr. Atif from where we left off on the pharmacist training program. You can share it now, Mr. Mahmoud.
Is it clear now?
Yes.
The pharmacist program, we have two types of pharmacist programs, one clinical pharmacist program, which will deal mainly with safe drug usage in these areas of low resources, drug interactions, and the rationale of prescription. But we have another arm which mainly entail the usage of herbal and traditional medicine. We are working on both arms, and hopefully in the coming few weeks you will start to see this material on our website as well. And then go you through some of examples of these clinically designed algorithms by the help of the AI. And this is an algorithm, for example, for patients with chronic diarrhea. Chronic diarrhea, by definition, diarrhea for more than 4 weeks. The first thing you do is to look if there's any red flags, like diarrhea in an old man or old lady above the age of 50, if there's any blood, if there's any weight loss, family history of malignancy, or family history of inflammatory bowel disease. If these red flags are there, you refer directly to a gastroenterologist and endoscopist. But if none of this is available, so they take a very good history and clinical examination and look at the type of diarrhea the patient has. If it is frequent, associated with abdominal pain, and of a small volume, this is most likely IBS or spastic colon, and you can try loperamide, which is usually very helpful. If it is watery diarrhea with blood, so you suspect inflammatory bowel disease, or in old patients, you can consider cancer, so he needs endoscopy. If it is watery diarrhea with large volume, so you have to review the medications and you have to review the surgical history for bowel resection, for example. If it is greasy, bulky, foul smelling, so you consider inflammatory bowel, you consider malabsorption syndrome, and you look for history of suggestive celiac disease or chronic pancreatitis or infections like Giardia. This is another algorithm for patients with osteoporosis, where you use the FRAX tool, which is easily accessed by the internet, and you classify patients according to the risk factors for fractures. If it is low risk, moderate risk, high risk, very high risk. If it is low risk, though we go on conservative approach, advice about lifestyle and calcium and vitamin D. If it is high, you go for therapy straight away without any need to do any radiological workup, like bone densitometry scan or X-rays or MRIs. You go for bisphosphonates or denosumab. beside the calcium and vitamin D, but if the risk is extremely high, very high, usually start by an anabolic agent and then shift to anti-resorptive agents. It's only if the risk is moderate, this is the time where you do a bone mineral density scan, and then you reclassify patients into low or high, and you manage accordingly. So IMA is, I believe, very important. It's a very valuable website for online education, as it focuses and gives you the following advantages. We do not use expensive equipment, and it's online, very easily accessible at any time. And we have built up surgical skills programs to help to build up surgical skills remotely. And we have also structures, a program for the interns, and we have used AI for enhanced learning in this platform, and not only for the medical group, but also for the volunteers and community empowerment by giving them more advice about how to handle. This is the different way you can join the academy, either by an email or through our website, or access by your mobile phone. And I believe you will find it extremely helpful for you. Thank you so much for your attention, and I wish you a very successful webinar. Thank you.
Thank you, Prof. Atif, for that important message. We look forward to having you with us, inshallah, in person at our next webinar, and we wish you well. Prof. Abir Omar, Professor of Nursing at Trent University and Chairman of Triple H Humanitarian Health Hub, will present how we are documenting and publishing the Gaza experience as a global evidence. Dr. Abir, the floor is yours. اتفضلي دكتور.
Your mic, Dr. Hazan, is muted.
No, I'm sorry. I was talking to myself. All right. Thank you so much, Asma, for introducing my part. And I'm going to talk today about the state of research. And specifically, I've selected Gaza because of the catastrophes and genocide that's going on for almost over 2 years now. There is an analysis in the media, in the peer-reviewed publication reports from international organizations, and actually they were increased once the genocide started in Gaza, October 2023. We have seen a growing body of research, but still we have gaps there. The importance of research to publish as regards to areas of underwar or conflicts has many advantage, but the most important of them is we are trying to shift from modern to innovative practice-based. And also, you will never convince the medical and nursing body of knowledge to change their practice until you have a research that's published in peer-reviewed journal and in a certain or specific types of research designs, such as randomized controlled trials. So these are the main aims that we do. For humanitarian aims and objective to publish research about Gaza is you are quantifying the invisibles, because there is a contradiction between the numbers that they are already published, but the numbers we expect are more than this. The other thing is to put the institutional pressure on other people for such as Human Rights Watch, United Nations, Amnesty International, to quantify and understand the catastrophe and the humanitarian crisis in Gaza. We also need to protect healthcare workers and document the protected persons under the international humanitarian law, putting their governments to notice of record for violations against healthcare workers and protected individuals in Gaza. We shift also the Overton window, like we transform the contested events into documented consents. So I'm trying here. doesn't go forward. Yes. As numbers for Gaza, and I think we are all aware with the publication that was in the Lancet in 2024, when they estimated the number that we received is very low according to the number that's actually happened, and they estimated that over 186,000 people are deaths in Gaza, and that was in 2024 only. To date, and that's like an iceberg that we see only a part of this. Today, according to the Ministry of Health in Gaza, they said there are over 72,800 deaths, and plus those in general, like 172,800 injuries, and the number is over than them because we have people still missing. We have around 2,900 children are missing as well. We don't know if they are deceased, if they are kidnapped, if they are under rubble. So we just see the iceberg, but this important research has changed the impression or the perception about this in Gaza. Other kind of research that they published about the weaponization of starvation or using starvation as a weapon. And I want to say that in 2025, in October 2025, our organization, Humanitarian Health Hub, has conducted a 3-day international conference. We have received, and it was about like using starvation as a weapon. We have received presentation and invitation or invited people from Amnesty International, international lawyers, human rights lawyers, scholars, university professors from all over the world, and they presented the effect of starvation on physical and mental entity. Other publication and research since 2023, they have shed the light on the emergency alert began because of the siege, because of no access to medications, no access to drugs, and they in 2024 they started to throw out the alarm that there is escalation going on, and in 2025 there are actually over 30% among the children under 5. And it's according to the Save the Children organization that they suffer from malnutrition. And I think this number is escalated as well till now. So this is according to the using starvation as a weapon. As regards to healthcare system, there are stages that led to the situation now. For phase 1, when they started the infrastructure damage, and we have under 30% now in 2026, under 30% of our hospitals. We had over 36 hospitals in Gaza. I think very minimal hospitals now are working under with not full capacity as well. Personal displacement of the civilian, the supply of the shortage, they led to the collapse. Like we have chronic disease failure, disrupted management of the diabetes cardiovascular condition and medications as well. The WASH or water water sanitation and hygiene. There were overcrowding and destroying of the sanitation of the place, which like pushed the emerging of, for example, skin diseases. And Humanitarian Health Hub, our organization now, is in a way of submitting a paper about the dermatological pattern or skin diseases in Gaza during 2024 and 2025. There are preventable deaths, but they are occurring because of the catastrophic conditions that the people like face there. And there are exceptionally high risk of multi-disease such as hepatitis, meningitis, respiratory infection. If we go to the other section about the legal record about international humanitarian law, there are some legal standards that they were issued around the genocide in Gaza, and there are some scholarly consensus and documentation as regard the same topic. the International Court of Justice in January 2024 ordered the State of Israel to prevent acts that constitute genocide. The International Association of Genocide Scholars, which is the only one in the world, it's globally, they declared that what's going on in Gaza is a genocide. And if you define a genocide, it's according to the intent to destroy, but actually what happened on the floor, on the ground, is destruction of everything. And there is a civilian harm when the law of armed conflict protection emerged. There are multiple research published as in Amnesty International, the Special Rapporteur, Francesca Albanese, when concluded there's reasonable ground to declare it's a genocide that's going on in Gaza. As regards to mental health, there are some research published according to the population in Gaza and healthcare workers at the same time. But there is a new paradigm emerged from the catastrophe of the humanitarian crisis in Gaza. We don't use the PTSD, but we use now the CTS. The CTS is continuing traumatic stress. People in Gaza still live in the traumatic stress. Like, the difference between both is when an individual experiences PTSD, it's in the past. They have returned to safety, they processing memory to reduce the threat, but actually with the CTS, the people are living in ongoing, inescapable present threat. And there is complete absence of safety, and we have seen every day there are children are killed, and there are extraordinary rate of acute distress across all age groups. As regards to the healthcare workers also, there's some of qualitative studies have conducted. Like some of them spoke about how mass casualty of management when the collapsed supply chains happen, where some amputations and surgeries are happened without adequate anesthesia, sterilization, or even imaging. There is extreme triage protocols and the reuse of single-use equipment put the people in hazards of infection as well. Clinicians are simultaneously treating patients while being deprived from their families, and sometimes they found their families as victims that they came to the hospitals. And there is a famous story about a physician who received her 6 children and a husband were killed. There is moral injury, like extreme rates of burnout. Still CTS, not PTSD, actually. We need to use this term, and insufficient care under occupation. What happened in Gaza is ongoing genocide, and I call it a slow motion genocide, because when you destroy the generations of the children, now you're destroying the future of the city or the future of the nation. When you deliberately prevent the food, the supply, the clean water, the medications, destroy the healthcare system, destroy all the schools and universities, you have weak generations of children, and the weak generation of children could not produce and be good citizen in the future. So what's actually happening now is a slow genocide in Gaza. If we go to the environmental women, what happened is there is a 37 million tons of rubble. They are mixed with hazard industrial materials. Some Israeli drones, they left some chemical and deliberately thrown some chemicals when they go to the underwater, to the sanitation system, and then the recovery, in turn, the recovery of water and environmental system will require decades to be cleaned. As regards to the media, we have seen suppression of some contents that are related to the situation in Gaza, when on the other side, there is a catastrophic putting on the surface some other contents against the reality that's going on in Gaza. In addition, killing of journalists, we have over 125 journalists who were killed. infrastructure for journalism. So it's another way of fighting the democracy and fighting the knowledge that go to people. For research ethics, we have two different research body. Like there are extra active scholarship when the people in Western world, when they try to search Gaza, they analyze the secondary analyze the data without local context. They treating population merely as data point. But what we need to do is centered scholarship. We need to center the Palestinian researcher and epidemiologists, and we handle the research according to the ethics or research ethics. And Humanitarian Health Hub, we have a connection with Helsinki a group in Gaza who approve the research according to the research ethics. We have also connection with faculty professors in Gaza. We have connection with healthcare workers. We have connection with hospitals. So I invite the practitioners, the pharmacists, the physicians to reach out to us. And if you have an idea for research, please reach out and we can put this idea in reality and in a shape of research. So this graph such just to show you how child malnutrition happened because of the many factors that are embedded in Gaza. The lack of research or the gap of research that we have seen, there are absence of longitudinal data. And I imagine because of the challenges that happen in Gaza, you don't have access to people or you lose the track of people because of the several displacement. Like I have heard that many families in Gaza were displaced over 100 times in that 2 years. So follow-up of people is one of the challenges to do the longitudinal data. Gender disaggregated data. We have seen a few research about women, girls in the reproductive age in Gaza, but we need to increase this. Comparative causality methodology, like how we can, like scholars can develop a framework to actually predict or prediction model to predict the actual number of people who were killed in Gaza. And I think it's one of the aim of Humanitarian Health Hub is to publish about innovative health practice solution, our telemedicine consultation, teletraining, the support that we provide to people in Gaza, the pharmaceutical department, and it's led by Dr. Metwalli, how to use alternative non-pharmacological medicine in treating the healthcare condition in Gaza. Thank you so much for your listening to me. Thank you.
Thank you so much, Dr. Abir, for your valuable presentation. We greatly appreciate your contribution and the insights you have shared with us today. Prof. Ahmed Metwalli, Professor of Complementary Medicine at Al-Azhar University and the head of our Doctor to Doctor initiative, community initiative, he will speak about the power of professional community and integrative medicine in low resource settings. Prof. Ahmed, the floor is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. At first, I would like to thank everyone for joining us in this essential and important webinar. We will talk today about the complementary medicine in wars, in conflict areas, and in low resource settings. At first, let's state that according to the WHO, the World Health Organization, about 2.4 billion humans in fragile or conflict-affected states. 80% of them cannot reach the essential medicines. 40% of them have a severe shortage in the basic medical supplies. Historically, the complementary medicine is not a new thing to do, but it was very important in all wars all over the history. The honey have been used as dressing in World War I and in World War II and before British and Russian mixed the honey and sugar with iodine, and they use it as a dressing. The honey itself used as it is in Eastern Europe and in North Africa in many wars and conflict areas. The Russian used the garlic several times as a disinfectant for the wounds. In the war, they called the garlic as Russian penicillin. The aloe vera have been used several times by American and Japanese. The comfrey and the chamomile have been used as compresses, as an anti-inflammatory against the inflammations and swellings. One of the strongest things are the maggot therapy. In maggot therapy, they use some some worms for deep wound cleaning. It's used by the British Army in Burma and in Egypt. The acupuncture have been used by Chinese. The cupping therapy have been used several times to decrease and control the pain. Today we will talk about 3 different topics. One of them have been used by our team in Gaza, and it was very effective last summer. We'll talk about the honey, the cupping, and clove water. The honey historically have been used several times for the wounds and as disinfectant. In World War I and II has been rediscovered. The honey has a great antimicrobial activity. The honey can work against fungi, against bacteria, against viruses. The honey has a great anti-inflammatory activity. The honey have a great effect in wound healing. It works through 7 different mechanisms. In different meta-analysis, and you can find the references in these slides, 43% showed faster wound healing and wound closure. The honey was very effective against, like the beta-cytosterol, the mepodermazine, against the usual. It was very effective. And in Egypt, in Al-Azhar University, a lot of professors use the honey in the diabetic food and in a lot of complicated wounds. The honey showed 5 times more reduction in bacterial load and showed more than 85% in increase in the chronic wounds, and showed improvement within only 2 weeks. The average amount of honey to make complete closure, it was about from 10 to 15 days, which was in usual and standard treatments from 20 to 25 days. The WHO endorsed the honey as a method of wound healing. Infield plaques have been used several times, and it's have a lot of benefits because it's very easy. Doesn't need the complicated situations to be stored. Doesn't need either a refrigerator. Can be stored at any conditions. Also, the cupping therapy, either it's dry cupping or wet cupping. The cupping therapy have been proved scientifically and medicinally to improve microcirculation and the lymph flow through the body, triggers endorphin release, and reduce oxidative stress and inflammation. Some diseases, the cupping give a great efficacy, like most of chronic pains, the back pains, the sciatica, shoulder pains, the spinal pains, the varicose veins give an excellent activity, but it needs sometimes. The sinusitis gave immediate relief, and we have a lot of experience with a lot of people. The fibromyalgia, our team under the supervision of Dr. Mohammed Yusuf has discovered this point, and we have a paper. It's ready for publication about the efficacy and the great success of cupping therapy in treatment of fibromyalgia. A lot of field clinics given the right of cupping therapy in treatment and in decrease and controlling the pain. The very important point in cupping is that it's very easy, doesn't need any out resources, doesn't need a lot of complicated precautions. In a meta-analysis for 1,359 patients, 40% of them showed an average of, all of them showed a 40% reduction in chronic pain. 20 to 25% of muscle recovery in athletes. And we found this, known photos, and it was shocking photos for a lot of athletes in a lot of in different fields of sports. 200% increase in the blood circulation, and less than 5% of adverse effect, and this adverse effect were very minor. The one thing we have used and we have endorsed in Gaza Strip, and it showed a great effect. It was very simple and very accessible. Last year, when with the start of the summer, just like these days, a lot of insect bites, and in Gaza Strip they have huge problems of a lot of insects. They were a refugee just near the the Mawasi areas. The Mawasi areas all near the sea, and a lot of insects were there. We use something is clove water. The clove water is the water extract of clove. Clove is Schizinium aromaticum. The clove buds appear in this photo. The active constituent is eugenol. Eugenol is a great antiseptic and anti-inflammatory and antioxidant phenolic compound, have an important and an essential antimicrobial and anti-inflammatory and regenerative effect. The method of preparation was very easy. Just you need 5 to 6 clove buds, crush and put it in clean water, boil for 5 or 10 minutes, and you can use immediate. It showed a great efficacy against eczema, dermatitis, insect bites, and several types of rashes. We got several messages from a lot of patients thanking us for this. However, there are some limitations in complementary medicine. The idea of that complementary medicine has no side effects is a wrong idea. You have to ensure the honey used is very pure and the original, not adulterated or not impure. You have maintained strict hygiene in cupping to avoid infections or overbleeding. Clove water must be diluted. If it's concentrated, it can be irritant. Cupping with bitter in patient with bleeding is contraindicated. So it's very important to choose. Our conclusion: resilience through simplicity. The complementary medicine is a great idea, and it cannot be cut, and it cannot be controlled. Nobody can cut these resources. So we trying to train a lot of our doctors in our community to do this complementary methods. Now we will talk about another thing, which is very promising and very lightful: the doctor-to-doctor community. Just few months ago, maybe 2 or 3 months, we started effectively to work through doctor-to-doctor community. We are so proud. In this community, we have more than 100,000 doctors. They work in more than 3 different specialties and subspecialties. 50% of these doctors are from inside Gaza. These doctors, starting from the young and the fresh graduated doctors till great and very big and senior consultants. In these subspecialties, we covered, like I said, more than 3 different subspecialties. Of them, surgery, pediatric surgery, cardiology, histopathology, pediatric gynecology, ophthalmology, rheumatology, hematology, ENT, ICU, psychiatry, radiology, neurosurgery, and the cardiac surgery. What we have done, we worked through 3 different pillars. The first pillar, and it's very important to keep the idea of second opinion very easy and can be reached 24/7 for all doctors inside Gaza, whatever these doctors are very senior or just freshly graduated. We made tens of grand rounds. These grand rounds conducted across more than 15 subspecialties. Real cases have been shared from Gaza Strips. Important notes have been discussed in these cases. And in most of the cases, the professors and the consultants from out of Gaza were amazed about the accuracy and about how much they are efficient, almost with almost no resources, but they did a great job. In addition, these doctors make a big difference in a lot of these cases in the treatment plan and in adding some things and in removing something, increase the concentration of some drugs, use another methods which are compatible with their low restricted conditions. We can confirm the global reach. We have, like I said, more than 1,500 doctors, half of them from Gaza, and the other half from the United Kingdom, most of the other half from the United Kingdom, from Egypt, from the United States, and from worldwide. We have a real-time second opinion 24/7. We have ongoing platform to communicate, to continuously learn, and to train. 1,500 doctors, 50% from Gaza, more than 30 specialties, and hundreds of challenging and hard cases have been discussed and have been efficiently introduced. Thank you very much for your listening, and I will be ready for your questions in question time.
Thank you so much, Dr. Ahmed, for the fantastic presentation on the complementary medicine, particularly the remarkable role of natural remedies such as honey in wound healing and recovery. يعني a wonderful reminder of the healing power found in nature. And يعني ومسك الختام Prof. Dr. Khalid Isa, the Professor of Orthopedic Surgery and the head of Global Fellowship Shadowing Initiative, will talk us on a tour regarding this initiative. Dr. Khalid, the floor is yours. تفضلي دكتور.
السلام عليكم ورحمة الله وبركاته. I hope the screen is working now. Yes, okay.
Yes, تمام يا دكتور.
Okay. Thank you for attendance of this valuable and important webinar. In this rapid presentation, I will try to focus on the practical points of our program. In this program, we will try to fulfill the clinical and scientific requirements of the postgraduate doctors in different specialties in Gaza under the supervision of some of the most qualified and eminent professors in different specialties. We started this program on the 4th of April 26. Actually, it started by Professor Dr. Izzat Afifi, which is a consultant of pediatric nephrology in UK. According to the requirements of the Ministry of Health in Gaza, they asked him to be a supervisor of a postgraduate doctor in the subject of renal nephrology in pediatric with how to take a renal biopsy. Actually, Dr. Izzat started this program by 2 sessions weekly, 1 session of academic subject and the other with sharing with the doctor the most important clinical cases either in Gaza or in UK. Nowadays, I think Dr. Izzat has progressed this program. He will be in Gaza to start a clinical and practical simulation with this doctor to how to take the renal biopsy under his supervision directly. And that's what we hope all our colleagues as mentors to do in different subjects. We started this program and try to progress it. Now there is cooperation with the Ministry of Health in Gaza. It fulfill the different subjects according to the requirements of the trainee and also the requirements of the local environment. It included both the basic concepts according to the requirements and the lack of facilities, and reached to the most updated practice according to the availability and the requirements of the postgraduate doctors. And there is actually a lot of help with the virtual process in reaching to our projects and hopes in this criteria. Now we have about 40 mentors and 20 trainees in different subjects, including pediatric nephrology, 1, hematology, 1, rheumatology, 2, endocrinology, 1, cardiology, 6, GIT and internal medicine, 2, emergency, 1, and hematology also, or as we said, 1, endocrinology, 1. We hope to fulfill the different specialties with different doctors. Actually, we have a lot of mentors, but up till now, according to the cooperation and arrangement with the Ministry of Health in Gaza, they asked us to make the trainee under their supervision. They asked to every board in every specialty to include one of the head of the supervisors from Gaza to reach to the goals that help the environment and help the requirements they want. And we hope we can manage this, and at the end of this year to fulfill all the specialties and to be, if we can, part of a board in the postgraduate sessions in Gaza, which include different specialties, and help doctors not to leave Gaza, which is very important issue in this position, in which anyone who wants to improve his qualification, he wants to be a fellowship in another country. And actually, this will lead to lack of the specialties in Gaza. That's why we are trying to focus to fulfill all the requirements and all the qualification required to help the progress of the medical system in Gaza. Thank you. And if you have any question, I will appreciate this.
Thank you, Dr. Khalid, for this valuable idea and initiative. We greatly appreciate your efforts and vision in supporting healthcare professionals. And actually, we look forward to expanding this initiative and training more junior doctors, helping them develop the knowledge, skills, and confidence needed in their clinical practice. Dr. Muhammad Yusuf, we're back to you again. The floor is yours.
Thank you so much for coordinating tonight. Actually, I think we have two important invitees. We have Professor Wael Sar and we have Dr. Muhammad Dawood. Dr. Wael, you are available? Okay. Actually, Dr. Wael is the ex of Bani Suef Faculty of Medicine and is the ex-head of plastic surgery department, and he is in charge of the Egyptian Board for Plastic Surgery. And Dr. Wael, with the surgical team, I'm honored to be one of them. We are preparing two amazing, one-of-a-kind. طب وائل مشكورا ممكن تجيب few minutes بس كومنت عن what we are making، حتى مش لازم تفتح الفيديو، what you are making about our skill online program regarding plastic surgery and laparoscopic surgery, if you are available.
دكتور وائل اتفضل، تقدر تفتح المايك دلوقتي لو
كنت
كويس.
بحاول افتح، معلش كنت مش عارف انميوت.
لا ولا يهمك، اتفضل يا حبيبي اتفضل.
Hello, Dr. Yusuf. Hello, our respectable guests. I was it was very important lectures. I had very important information from the previous valuable speakers. That's what I used to receive from my professor, Dr. Yusuf, when he's moderating such important ideas or webinars. For our small projects we are doing, and to do a remote training program for the junior surgeons or for the young surgeons who cannot do the simple procedures in plastic surgery or laparoscopic surgery. So we are two teams together. Every team is working independently according to his specialty. So in our specialty in plastic surgery, we have some small maneuvers or some small techniques which the junior registrar or junior resident is in total need in the department and the emergency department, like skin grafting, fingertip injuries, burns, dressings, something like this. So we can do it in a very simple models. We can do these models and give it in 3 to 5 minutes videos. So he can do it himself, and we can communicate with the junior surgeon to see if he can do the assigned flap or type of surgery, type of dressing, and so on, with small technical or some theoretical maneuvers. Thank you, Dr. Muhammad.
Well, thank you so much for clearing this issue. Actually, I'm pleased. I'm very glad that we started to communicate with Al Shifa Hospital Department of Surgery there, and we are arranging a totally online training program, which entail part of it theoreticals and part skills with them, and hopefully we will start in 2 weeks. And actually, this initiative was pushed by my colleague, Dr. Muhammad Dawood. Dr. Muhammad, أنت معنا محمد؟ you are available. Dr. Muhammad Dawood, يعني الحمد لله, he just came back safely from Gaza after doing a marvelous job. Muhammad, ممكن to give us your insights, please? ممكن محمود تفتح المايك لمحمد بعد إذنك؟ محمد داوود. محمد.
الو.
تمام.
الو دكتور محمد.
تمام محمد، اتفضل يا حبيبي.
كل عام وحضراتكم بخير وعيد سعيد على الجميع.
محمد, please give your insights in English. We have wonderful MPTs who want to understand Arabic, please.
Okay. Eid Mubarak for everyone. I just came, as Prof. Muhammad said, I just came out from Gaza 1 week ago. Actually, it is a disaster inside, and what we see is the TV is 10 times inside. So I think everyone should do his best to help them. Are you hearing me, Dr. Muhammad?
Yes, ma'am. Go ahead.
So I think everyone should do his best, especially the boxers from the CPs. So everyone should do his best to help. 1 second, Dr. Muhammad, 1 second. So I think everyone should do his best to help them. They are a lot marvelous. They are very good doctor inside, young doctor and the consultant. They need hand. They're working for emergency cases for more than 2.5 years. So they lost some skills, or they need some support from us for maybe decision making, for some laparoscopic skills, some ideas for to help them. Honestly, there is no instrument inside. They try what they have. They coming from. I was in the Chica hostel, so what I see, only instrument they can save it from the rubber, and they try to use it multiple times. So some instrument, basic thing, maybe you don't found inside. They try to create their own thing to keep working. Some facilities not there, like a simple thing. There is no radiotherapy inside. Are you hearing me?
Yes, Muhammad.
So, like, there is no, like, simple thing is patient with breast cancer, they have to do modified radical mastectomy instead of breast conservative, as there is no option for radiotherapy, or the patient can take the risk herself to get out, and most of them don't get out and they get recurrent again. This is some of the problem inside. What else? There's some deficiency of the sutures material, and some staplers. What else? They have some like consultant wise. What the working, like in the surgical, I chat about surgical department. There are 20 consultants. What's left now is only 4. Some of them kill stushhead. Some of them get in the prison. Some of them getting out. So what's the remaining is 4. So we need to keep supporting. Even they told us psychologically, even when you see us working with them or helping them, they mention this is give us push to continue. So as much as we can, we try to do our best. I chat with Dr. Muhammad. We get communication with Dr. Muhammad and the surgical department to give them hand in the laparoscopic stuff, teach them or learn them some tips and trips. So we going in this position. In the other specialty, they are suffering loads. Honestly, from what I hear from my colleague, pediatric, they have very shortage in the pediatric surgeons there inside. Pathologist, maybe just one left inside. In the different specialty. So I think this webinar or doctor to doctor workshop, it will help them very much. Okay. And everyone make this sake for in good deed for the sake of Allah, inshallah.
Yeah, thank you so much, and welcome back, alhamdulillah, safely. Actually, I have another, I think, promising announcement that there is a team preparing a wonderful infection control program, especially designed for people or health professional working in low resource settings. They will share with us new trends in making infection control in such restricted resource, and I think this program within 3 to 4 weeks will be finished. The floor is yours, Asma. Please continue. If you want to open the floor for any question, this would be great. And I think now we are approaching 1.5 hours. Please.
Can I ask a question for Dr. Dawood?
Yes, okay. Okay, Professor Amir.
Dr. Dawood, how do you see the access for internet and network for the healthcare workers there, for physicians and nurses? How could we accommodate them as regards the access?
Muhammad, can you answer, please?
Actually, there's no internet there. The only internet in the hostel. The people, there is no electricity, no internet. They use same phone from Israel, only to talk and send the message, but only internet in the hostel. And some of the restaurant or the shop, they have internet and we have to pay for it. So it's limited. Not every time they are available. Only in the hostel, or I don't think anyone have router or anything in their home. They just using from sometimes in some cafe or something. You have to pay 2 shekels or 3 shekels to give you access for internet. So internet is local only for small places, not everywhere.
So if the physicians and healthcare workers there will watch our modules online, it should happen during the time when they are in a hospital.
Yes, or they come at the night besides the hostel. Like I was myself, I was examiner for the students also while I'm staying in the Gaza. One of the students told me I walk 60 kilometers to get some electricity or some internet to study. Honestly, I tell him you are here. Honestly, 6 kilometers to just get some internet to download the material. So I think e-learning it will be good for them, or if we can choose good time to everyone be around, it would be great. I'm not sure what is a good time for them, but we'll work around this what they have.
Thank you so much.
Okay, dear participants, the floor is now open for your questions, comments, and suggestions. And we would be dedicated to hear your thoughts and feedback.
Assalamu alaikum, everyone.
Alaikum
I have
salam.
a question, if you permit. Thank you very much for holding this webinar. I want to say Kull Aam Tum Khair and Eid Mubarak to everyone, and thank you for your services. Mr. Muhammad Dawood, my question is for you. I want to say thank you for your service, and we're glad that you're back home safely. Did you see anything that was out of the ordinary in terms of prioritizing pediatric services you highlighted? Please do share some more insights.
Can you say your question again, please?
Yes, you highlighted some of your experiences firsthand. What experiences did you find drastic, more specifically to pediatricians?
No, I'm not the pediatrician, but what I heard from my colleague is that like intersex or patient will have the common channel. These children, they are suffering. Like there's some, like when you have baby, they're asking you what you have. It is male or female, boy or girl. Some families they can't get this answer. They have children who born during the war and they have like common channel, what you say, kulwaka, and you don't know it is male or female. This we have, like my colleague who was very surprising. He mentioned I see 6 cases. Like you can see one case like per year you can see 2-3 cases. You have some cases like this neglecting treatment due to the war. And he showed me one of the case, and he was like the family, like this is, as you know, from our Arab nature, this is very preaching our family. We don't know the sex of your child or the child is ambiguous genitalia or something like this, and we can treat it early if you have surgeons inside. But this is what I get it from my colleague.
Just a follow-up question here, Dr. Muhammad, are these genetic cases that you're seeing? Genetic anomalies? Just to clarify.
I'm not sure. Not sure this is genetic or from the war itself, but this I'm not pediatrician. I am the general and upper GI, but this is what I heard from my colleague. I have one of my colleagues from UK, and he works now in the Emirates, and he showed me some pictures for this patient, and he showed me one in the theater.
Thank you for informing us, Dr. Muhammad, and welcome back.
Okay, thank you so much, Dr. Muhammad. Dr. Abd Sayed has a question. So please, Doctor, open your mic and go ahead.
Assalamu alaikum. دكتور مستر عبد الباسط من ايرلندا. Thanks, Dr. Mr. Yusuf and your team for the great work you are doing. My question for Mr. Khalid Isa regarding the shadowing fellowship will be assert at the end how long it takes and will be recognized from a certain university. Thank you.
Thank you for this question, Dr. Abdul Basit. Actually, as regard to the university, no, but there is a lot of cooperation either between us and the Ministry of Health of Gaza, according to the board inside Gaza, in parallel with a lot of curriculums from different universities. But we are trying not to focus on specific curriculum because this is a flexible and malleable program according to the requirements of the lack of facilities in this area and also according to what the trainee needs. As regard to the second question, with the period of this program, it differs from one to another, but we try to make revision for this program every 3 to 6 months according to the plan from the mentors. We ask every mentor to put a specific plan for his supervision, and we are following this plan according to what the achievement has been done, and this review every 3 to 6 months. At the end of this plan, what are the hope to follow the criteria required and achieve our projects? It may differ from one to other. We will not give PhD, we will not give any scientific degree. However, this can be used by documentation as the fellowship period. According also to what we are agreed with the Ministry of Health in Gaza, this can be put in the CV of the candidate and may help him to decrease the period of internship or period of training according also to what they decide from inside Gaza. I hope I asked this question clearly, Dr. Abdul Basit.
No, sir, thank you. It's clear that it is recognized inside Gaza, and yeah, that's good. Thank you.
Okay, Dr. Khalid, allow me to just add one point. Thank you so much for your answer to Dr. Abbasid. And as you mentioned, it is a starting program. It is an agile one. We are going on and assessing, and we make some sort of modulation. So in Arabic, it is some sort of tabanni. It is not. There is no curriculum, but someone will join another one. A junior will follow a senior. They will talk together, giving support, trying to solve problems like what Dr. Izzat Afifi done with the young lady who cannot do a renal biopsy. And as you just mentioned, it is a flexible, agile, and we can be recognized and give a model to be validated. Thank you so much for this. Asma, would you please, if Dr. Reham available or not? You are available? I cannot see her. Yes, Dr. Ham is available. You hear me? Okay, if you have time or you can join us for a few minutes, just Dr. Ham is the regional medical of Baytul Mal Association. Baytul Mal is a reputable USA association. She is working in conflict zones for humanitarian activities. She is working Middle East, Gaza, of course, Lebanon, Sub-Saharan African, and hopefully we will have some collaboration and partnership with her. So, Dr. Reham, give us a few minutes about your activities. Okay, I think she is busy. Okay, back to Asma, please.
Okay, دكتور كامل البلتاجي has a question. تفضل يا دكتور. Dr. Kamel, just unmute yourself and open your mic.
Here?
Yes, تفضل يا دكتور.
I am asking about, is there any place for giving courses of first aid for the lay people? Because the catastrophe occurs with big numbers of persons who are injured. And the normal healthcare services may not cover this within the few minutes after the collision or after the problem. So is there any chance to make courses for first aid to the population to save lives, especially for these fatal things, which like flail chest, like fractured ribs, or like severe bleeding, like shocking pain of fracture and so on? Is there any place for this?
Asma, please answer.
Yes, actually, Dr. Kamel, we have if you visit the school of us, Integrated Medical Academy, you can find a program that's called public program أو البرنامج الموجه للعامة. In this program, we created more than 15 mini courses regarding the first aid that offered to the population, as you said. So we train them on how to manage wounds, how to manage burn, actually how to carry a patient from side to side. So actually we have this program that you suggest.
And actually, Dr. Kamel, it is in Arabic. And as Dr. Asma mentioned, we are very pleased to have this module about safe transfer of patient. And I think this is one of the gaps. And alhamdulillah, one of the senior anesthesia and ICU professors had done a wonderful job making this.
Okay, thank you.
More than welcome, Dr. Kamel. If there is any questions or any comments before closing. Okay, so I think
السلام عليكم.
عليكم السلام ورحمة الله وبركاته.
دكتور اسماعيل نصار من غزة، مستشفى الشفاء، pediatric surgeon, chief of pediatric surgery in department of in Ship Hospital.
أهلا دكتور إسماعيل منور.
حبيبي بارك الله فيكم وكل عام وانتم بخير. و I appreciate your efforts in this webinar. I hope that will be continued to assist our people here in Gaza. Many thanks for you and your team who are working daily and helping us. I would like just to inform you about the congenital anomalies, and Doctor who mentioned about the genitalia and anomalies in genitalia. Unfortunately, even chromosomal study, we cannot do it in Gaza. In the past 3 years ago, before this war, in Islamic University and another center, we can send for the chromosome study, and we get male, female, XY. The gender can be exactly, and even ultrasound. The consultant of ultrasound operator dependent, some of them unfortunately left Gaza.
I was impatient.
Yeah, you can hear me?
Yes, yes. Go ahead. Yes.
Yeah, I would like just to inform you about the shortage and the lacking instruments. Even CT scan in Gaza hospital nowadays. Just we have 4 CTs. MRI we haven't here in Gaza. MRI, 3 system, 3 apparatus destroyed. One in Shifa. In Shifa hospital nowadays we haven't CT scan. You know. In Gaza City, just the CT scan. 2 in Middle East, Middle Governorate in Deir al-Balah, we have CT scan 1. In Khan Yunis Nasser Hospital, just CT 1. Consular we cannot do here in Gaza. The instruments even destroyed and stored. Many things. I don't like to talk about the difficulties here in Gaza and facing the medical team, but I would like just to inform you we are working in very difficult situation. According to the pediatric surgery, 2021 I started to make a program for training my doctors in Gaza. I am the chief of board of pediatric surgery. So nowadays I have about 10 doctors training in pediatric surgery. R5 I have 3. R2 we have also 5. R1 we have 1 doctor. R4 we have 2 doctors, and even 2 doctors in Egypt now. One in Mansoura Hospital, Mansoura Hospital, Dr. Hala, making it program after her father Martha went to Egypt, and I arranged for her with Dr. Mohammed to continue training program in Mansoura Hospital for pediatric surgery, and inshallah she will return to continue with us. Inshallah. Anyway, we need your help in continuing our program. Unfortunately, even the internet is not available everywhere. You know, as Dr. Mohammed mentioned, if you will join the internet, you have to go to the hospital and or to go to the market or somewhere with available internet, and it's not easy for the doctor to. This is one of the problems for connecting others. All right. Other problem we have, I would like to talk about in this war, especially in this war. You know, even the families of doctors are suffering. You know, the doctor, especially the surgeon. The surgeon need to be in the hospital, and in the same time to have to look for her family. It is not easy to help them. You know, and this is one of the most difficult situation I faced. And you know, some doctors families traveled outside of Gaza to be free to work in the hospital, you know, and this is not easy. Inshallah, in the future we will we will see you in Gaza. Hopefully I think in the future not Gaza, Palestine will be free, inshallah. And we will meet you here in Gaza, inshallah.
Inshallah. Thank you so much, inshallah. Dr. Magdi Abdu, you want to give a comment, please? In 2 minutes, because now reaching 2 hours, Dr. Magdi. Dr. Magdi Abdu. Dr. Magdi Abdo, unmute your microphone, please. Engineer Mahmoud, please do this job for Dr. Magdi.
Everyone can unmute themselves actually Dr. محمد.
طيب يبقى شكرا يا محمود، ربنا يبارك فيك. دكتور مجدي لو حابب، عشان احنا كده approaching 2 hours. اهلا اتفضل يا مجدي، اتفضل يا حبيبي.
ايوه السلام عليكم. الحقيقه ساعه ونص very rich and I really thank every speaker for outstanding talks and especially the doctor coming back from Gaza. Really أنا بحسده على المجهود اللي عمله، والحمد لله على السلامة. بالنسبة للدكتور كامل he mentioned
Magdi, please try to speak in English because some of the are unable to understand our please.
Yeah, for Dr. Kamel, he speak about the education of the lay people about emergencies. I know the health authorities in Gaza, they are overwhelmed by too many things. And I think our Triple H, not everybody knows about it. They have to work more to be acknowledged and to be known by even physicians in Egypt. I speak to many friends, nobody knows about it. And this needs extra effort. And also, in Gaza itself, if there is a local broadcasting, they can advertise for the site, try to expand the service and to help people in more practical way. This is my question. Thank you.
Thank you so much. Thank you so much. طيب أسماء، أنت بدأتي انهي بقى.
يعني I will leave the closing remarks to you, Dr. Muhammad.
طيب اوكي. لا دكتور عبير، انت بقى يعني please take the lead and share with us your insights about the closing remarks, please.
Thank you so much, Dr. Muhammad. Do we need to answer Dr. Magdi's question about affordable solutions for the healthcare workers there for the internet, or?
Actually, it was not Dr. Magdi. It was I think a comment regarding Dr. Muhammad Dawood and Dr. Ismail. And I think what we practice, as you know, we have a weekly meeting with training department of healthcare authority, and now we are starting a weekly meeting with surgery department. My impression that is better than I expect, and as you know, we followed at the Integrated Medical Academy after e-learning consultant a policy that it's better to put our programs, our module in asynchronous short videos, and are going to develop this application will work offline, so anyone can upload, and when just a touch of internet come, all this uploaded will be taken to the consultant. So I think we exhausted what to call our athletes to ask them what is the better. And as I just mentioned, alhamdulillah rabbil alameen, هذا فضل ان احنا now we are developing skill courses in laparoscopy, plastic surgery, and coming soon vascular trauma, as well as out-of-box control, in addition to the programs Professor Atif mentioned. So I think alhamdulillah, we are trying. وَلَيْسَ الْإِنسَانِ إِلَّا مَا سَعَى. And really, your effort. You are the one who initiated this sponsoring body Triple H at Canada. Thank you so much, Professor Abir.
Thank you so much. So I'm gonna close now. Thank you so much, everyone, for being here for full 2 hours. And I think today we exposed what we are doing in the Triple H, plus the Integrated Medical Academy. They are two entities connected to each others. We have multiple departments. We have telenursing training. We have telemedicine training. We have a research department. We have also other department for telemedicine consultations for the public. If you see yourself that you can contribute, and I want to mention that all our efforts at Humanitarian Health Hub is from personal contribution. We personally contribute to our financial requirements. There is no other entity like until now helping us, of course, except a few who volunteer. And most of the people here are volunteering, actually, their time, their effort to help for our humanitarian aim in Gaza. And I want to say that's the least that we can do for our brothers and sisters in Gaza. Like, we are honored to contribute to the healthcare worker enforcement of their skills, and when they suffer on the challenges and face challenges during this difficult time of genocide. And it's collaborative approach. We hope everyone who are interested to reach out to us. We have posted our website links if you want to get an overview about the activities. Thank you so much.
Can we have a group photo if just we give 2 minutes so that people will open the video? And Mahmoud, please. Yes, please. Thank you. ما شاء الله دكتور مجدي, you became an old man. دكتور مجدي عبده, ما شاء الله.
لا شباب ما شاء الله, شباب لسه شو الاولد مان شو.
لا
شباب ما شاء الله.
مجدي يا دكتور مجدي اصغر مني سنتين يا دكتور اسماعيل. انت بتتكلم على ايه؟ اصغر مني سنتين.
هو عنده كم سنة؟
هو عنده 70. هو عنده 70.
لا لسه شباب. شو 70 بعدين تقول لنا يعني ختيائية. احنا شو شباب. يعني عندك 72 سنة دكتور؟
لا انا عندي 72 بس يا حبيبي.
لا شباب شو 72 لسه. احنا بدينا. يعني انا كم سنة عندي انا بالك؟
لا ما هو انت برضه هتلاقيك كده اواخر ستينات ولا حاجة.
لا انا 50 سنة. شو
طيب.
اوه يا راجل.
بخليها مقصوعة يا حبيبي. خليها مقصوعة بعدين.
خلتنا اتكلمنا يعني.
طيب احنا ممكن يا جماعة نفتح الفيديوز اذا كان ممكن، يعني ناخد دقيقة كده اللي يحب يعني يظبط كده القميص ولا حاجة يبقى
مش غلط برضه.
If you could open your video, or if you're not interested to open your video, you can keep your photo, because we're gonna take a photo for this participants in the webinar.
اسمع أو محمود، يعني هنعمل ايه؟
يعني I will count to 3 and then I will take the
طيب
pictures. So 1 and
عمر فتح الفيديو وبعدين قفلت له يا عمر.
No, Omar is on. Omar is on. No.
طيب ماشي.
okay. So again 1, 2 and 3.
Just I'm gonna Patricia, Pissy, Ranzi, Hafsa, and Doris, if you are interested to open the video.
عبد الرحمن، ايه يا عبد الرحمن انت فين؟
Yeah, my video is opened.
طيب.
Oh, thank you, Doris.
Okay, so 1 and 2 and 3. Okay, thank you so much.
شكرا جزيلا. تصبحوا على خير جميعا.
Thank you. Thank you so much. Have a wonderful evening, everyone.
Thank you.
إن شاء الله نلتقي بكم دوما على خير بإذن الله.
إن شاء الله.
إن شاء الله. إن شاء الله.
والاجتماع القادم في فلسطين بإذن الله.
يا رب يا رب. ربنا يحفظكم.
الله كريم. الله كريم. الله يحفظكم.
السلام عليكم.
نراه قريبا يا دكتور. نراه قريبا والله.
إن شاء الله.
بإذن الله. بإذن الله. نحن على يقين.
يا رب.
إن
والله
شاء الله.
you are the true hero. والله يا دكتور, you are the true hero.
والله.
We
يعني
cannot
الحمد لله.
imagine the challenges and the struggles that you have in healthcare there. You are the hero.
أنا والله الحمد لله يعني أجرينا عمليات لجراحة الأطفال في غزة في فترة الحرب. لم يعني ما كناش نتوقع إنه إحنا نعملها في يعني في ظل الظروف الصعبة هاي، لكن ربنا سبحانه وتعالى يعني مفضل علينا بنعمه إنه يسرنا وسهل لنا واستخدمنا في خدمة أبناء بلدنا، وإن شاء الله ربنا يثبتنا دعواتكم لنا إن شاء الله.
آمين يا رب.
آمين.
آمين يا رب. آمين
ربنا
يا
يبارك
رب.
فيك. ربنا يحفظك
الله
فعلا.
يا رب.
You are the heroes يعني. الله
لا
يكرمك.
والله.
يا رب.
الله يحفظك.
السلام عليكم.
أقل واجب هذا نعمله لوطننا ولأهلنا ولأمتنا.
ربنا يبارك فيك.
يا
الله
رب.
يحفظكم
يا رب.
ويبارك فيكم. نلتقي على خير إن شاء الله. السلام عليكم.
السلام عليكم. السلام عليكم.